So my name is Eva. If you don't know me already, I've done a few sessions before, so hopefully you watched them. And today I'll be doing a session on critical care. I'm not going into too much of detail into it. Obviously, it's a very vast topic. So I've picked out certain things that I felt might be useful to know, even if you're not exposed to critical care before. So I just picked on certain topics. And obviously, this is by Bike Medicine, and they're an online platform where you can get your question banks, which are a multi-step single-based answer method of answering questions. So it gives you a more insight to the topic. They also have several online textbooks, which are constantly updated by many groups of doctors, so you can rely on them. So the aims and objectives that I will be covering today is basically I'll be going through the CRISP algorithm on how you assess a patient, the criteria for ITU admission, and the common drugs that you would use in ITU. That is a vast topic again, and I would be explaining the doses a bit. So if you have something to write down, I think that would be pretty useful. So I'll start up quickly with a clinical scenario. I've got a 45-year-old woman who is admitted in the ward following an L4, L5 laminectomy, decompression done 7 days ago. On day 6, she develops tachycardia and is noted to be running a temperature of almost 38.4. She also reports some chills and rigors associated with it. Her bloods show that her WBC is 18.4 and her CRP is 278. A diagnosis of sepsis is made and she is started on broad spectrum antibiotics. The source of infection is yet to be determined. And on day 7, she develops desaturation episodes with stats of almost 76% on room air. And the patient is currently in the ward awaiting further assessment. So if this was a clinical scenario that was given to you, and this is obviously a post-surgical patient, a post-op patient, this is when you apply your CRISP algorithm. So your algorithm as such, this is an image that you have to get into your head. It's pretty straightforward, pretty simple, no big hassles about it, but you should just make sure that whatever scenario it is, if it's a post-surgical patient especially, this is the image that needs to come into your head. So we've got immediate management, which is your ABCD, which is pretty much standard for all kinds of protocol, even your ATLS or your ACLS. So it's the same thing. In addition, though, to what is different from the rest is that in this is an inpatient, the patient is already in the hospital. So you will be going through the charts, the previous drugs that the patient was started on, what surgery was done, what operation notes, or was there any complication from the surgery and all of that. And then you decide and plan what you want to go. If the patient is already stable from your ABCD approach, then yeah, you can go back to your daily management plan. If the patient is still unstable, then it is up to you to stabilize the patient. So then you will decide on what treatments that you will be giving. Would the patient need a HDU management, an ITU management? Do they need any urgent surgical intervention, or do they need any further investigations? And then decide. So initial assessment, like I said, your ABCD, we will be looking into them a little bit more detail. You will check if the patient is speaking or not speaking. When it comes to breathing, you will check what the respiratory rate and how much effort the patient is putting. You will check how much saturation they are maintaining at room air and how much they're maintaining after you started administrating the oxygen, to see if they're tolerating the oxygen support. And also see how much of oxygen is being required for the patient to maintain it above 98 degrees, obviously. You will check what the breathing pattern is, and at this point, request a chest X-ray as well. When it comes to C, heart rate, pulse volume, character, blood pressure, CRP, and ECG, you will definitely, and you will also have to check for capillary refill. That is what I meant by CRP. Sorry, that was wrong on my part. And when it comes to D, pupil size, glucose level, and GCS. D is 3 things basically that I always keep in mind: pupil size, glucose levels, and GCS, or ABPU at least. Exposure, which I don't think a lot of people do, but you should do it at least when you reassess your patient at D. So you do A, B, C, D, you reassess the patient. Once you realize that the patient is a bit more stable, then you can expose the patient and start looking into everything else. That also comes as a part of your history and examination, which you will be applying to your CRISP protocol. So airway management. Simple way to break it down is to see if the airway is compromised or not compromised, and if the patient is conscious or unconscious. Is the patient speaking to you, responding to you? Even if he's confused, is he able to make any kind of noise, any response, even confused speaking? That means that the airway is patent. So if the airway is compromised, then the first thing you do is inform anesthetist, because at one point or at any point, it will come to a point where you cannot manage the patient on your own, regardless of your bag valve ventilation, your oropharyngeal airway, your nasopharyngeal, your laryngeal mask, which are all the things that you might be ready to do and you can do. But then despite doing all of this and despite giving that much of oxygen, you can even start on 100% of oxygen, patient might not be tolerating. And if you decide to call the anesthetist after that, it might just be too late. So if you see that the airway is compromised in any way, inform the anesthetist. I don't think they would mind if you call them at that point. And if you see that there is no airway compromise, then you can start up in your stepwise oxygen administration. I covered a bit of this in my previous session of respiratory failures, where I said each cannula, mask, rebreathing is all at different levels of oxygen. You can start cannula at like to a maximum of 4 liters. Anything above 4 liters, you would have to go for a mask or a non-rebreathing mask. And then obviously if they're still not managing and they've got poor respiratory efforts secondary to some chest compromise, always you can try CPAP or BiPAP. Anyway, I've mentioned all of this in my respiratory failure session. And breathing. So reasons, you do look for reasons for respiratory compromise. It could be just that they've got severe pain, that they're not taking enough breaths to breathe in through. Maybe they've got a chest injury. So you will be looking into all of that. You have to think of all of that in your at the back of your head. And meanwhile, once you start at 15 liters of oxygen, always start 15 liters of oxygen. When you come and see that if they call you for a high news, or if they see that there is even a little bit of respiratory compromise or stat stroke, do not hesitate. Don't start at 10 liters, 7 liters, or the patient is maintaining at 90%. So I'm going to start only 7 liters of oxygen. No. So start it on 15 liters, because you don't know what the previous partial pressure of oxygen in the blood is. So it is always better to start at 15 liters of oxygen. You can always reduce it further. I mean, there's no harm done. If you know that the partial pressure of oxygen is good, you can always bring it down from 15 later. But it is always better to start at 15 liters initially. Then quickly assess, check if there's any tracheal deviation. That gives you a clue if the patient has developed any spontaneous pneumothorax secondary to any procedure that you've done, or any other complications that can happen. Percus and auscultate. Check what the saturation is, check what the breathing pattern is, check if there's equal chest expansion on both or reduced on one side. And like I said, check if there's any visible chest injuries. It might have been missed in the first instance. It might have been not, when a patient comes into ED, not everything is actually checked. The initial role is to like stabilize the patient. They might not fully expose the patient and check on everything. So there's no harm in taking a second look to see if there's any visible chest injuries. And yes, ask for chest x-ray and take an ABG. And ABG, I think, in any acute scenario is one of the best investigations that you can do. When I was in ICU, like I would always ask for ABG as soon as I come to the place. And I don't know, some people might not be really good in taking it, so it's better if you give them some extra time to actually take it. So the first thing that I always ask is an ABG, and it gives me a lot of clues as to if the patient is hypoxemic, or if there's too much of CO2 retention, or if it's just an acid balance imbalance gone, like in acidosis. It also gives me an idea of the electrolytes, the sodium, the potassium, the glucose level, the lactate level. Pretty much everything comes in an ABG. So for me, at least in a critical care scenario, an ABG is a must investigation that you must do as soon as you come to the scenario. So either ask someone else to do it, or talk to the patient, assess the patient, and do your ABG on the side yourself. And Circulation management, yes, check for blood pressure, heart rate, and capillary rate full time. If you know that the blood pressure is dropping, or if it's even slightly less, just start on, this is for an ED patient, yeah, start on 2 large gray cannulas. Or if you see that there's a blood pressure compromise, start on free flow of saline. And it's okay to start saline at this point, because if you start heart or something and there is already an existing high potassium level, then you're putting your patient in harm. So might as well start as saline, and then you can change it later into whichever crystalloids or colloids that you prefer. So I always at least prefer to start saline on the first go and then decide which one I want. And obviously when you're putting in your cannulas, you can always take your routine bloods and your culture. Don't take it when you put in your first cannula, because you still need to make sure that your blood pressure is being maintained. And it might be a difficult cannulation, so don't delay that. Just start the fluids, and when you get the next cannula, and try to get all your blood samples ready and get your samples done. And also, when you give free fluids to the patient, always catheterize the patient, or always monitor the input-output in some way. There were so many situations where someone gives fluids, oh, the blood pressure is low, I'm going to give all the fluids that I can. Blood pressure might not be too low, but then, yeah, they might still give in all the fluids. And the patient, being in sepsis, might have already had kidney damage, or could be like a chronic kidney disease patient in which all that fluid is going to retain somewhere in the body. And you might not even notice it until like days later, because you haven't catheterized the patient and you haven't monitored how much of output is coming after your massive input that you've given. So whenever you prescribe fluids, always make sure that the input-output is monitored in some way. If they're wearing diapers and if it's difficult, just catheterize the patient, just to make sure that you don't have any difficult complications later. But keep in mind, yeah, they might develop an UTI, so that's the pro and con that you might have to weigh and decide which. But I would say catheterize the patient, because I think retaining fluids is much more severe than developing a UTI. Yeah, get ECGs done. Disabilities, which I said, your GCS and AVPU. If you're in a neurology or neurosurgical ward, stick with GCS, don't do AVPU. But in general, in medical wards, at least do GCS. It is much better and it's much more useful than an AVPU. But if you're not well versed with your GCS and you can't do it on the spot, feel free to do AVPU. That will help you with your presentations. Then yes, pupil size and sugar levels. Sugar levels is something that I think a lot of people forget. And a lot of times, like in seizures or even drowsiness, sugar levels is what the problem is. It could have been hypoglycemia and the patient is just drowsy because of that, or had a seizure because of that. And it often gets missed so much. So, and a quick general assessment, like I said, you could just, after you reassessed and you've stabilized the patient, you could always just quickly expose the patient, check if they've had a surgical site, check how the site is, check if it's bleeding, check if it's infected, check anything else that can go wrong. If they've got an PICC line, or if they've got a catheter line in general, just check if there are any infections there. That could be your source of infection. So just keep an eye out for all of those. And then once you've stabilized the patient, once you reassess the patient, and you know that it's all okay, the patient is recovering, his BP has improved, his saturation has improved, go to the nurse, ask for the history, ask for what has happened, how was the patient just before this happened, how long has he had saturation drops, how long has he had temperature spikes, check all of that. And yes, in CRISP, you go through the operation notes properly to see if there were any complications in the surgery. It could be that the clip had become loose, or they might have had to clip twice, or they could have had some hemorrhoids during the surgery, and there could be like a suspicion of bleeding inside later. So it's always better to go through the operation notes. And drugs assessment could be just a reaction to drugs, could be morphine overdose, could be fentanyl overdose. It's quite common, actually. I've seen quite a few patients with morphine overdose because their tolerance in general to morphine is very low. So even a small dose of morphine, which you think is pretty normal, is probably too high for that patient, and they would have had respiratory depression because of that. So you take a look into that. And also you check into lab results. What are the recent bloods? Like how long has that potassium been high? How long has that sodium been low? How is it trending? Has correction been given? How did the patient react to the correction? That's all probably something that you will look into before you make your final diagnosis as to is the patient stable or unstable. And investigations, all your routine bloods, like I always say, get full blood counts, CRP, use an ease. If you want LFTs, depending on what the operation is and what are the specific investigations you want, send for cultures, because this patient you're looking in for sepsis, always ask for urine culture, blood cultures, and chest x-rays. CRPs, echo, if you think that the patient is retaining fluids everywhere and it could be a cardiac cause. ECG and ABT, like I said, ABT, I would underline 3 to 4 times because I feel like it's really important. And scans, yeah, get CTs done. If there is a surgical complaint and the patient had a surgery and you think a CT is warranted at this point, then to get a CT. Things to be considered, like I said, at this point is immediate vital organ dysfunction. Is there any significant drop in your EGFR, or is the patient does the patient have significant respiratory compromise? What are the immediate therapeutic and supportive interventions that you can do at this point? What can be done by the other teams? What can you do? What can the nurses do? Even something really small like keeping the head end elevated, or keeping the patient at 45 degrees, or even if there's like increased ICP, like I said, keep the head end elevation. Small things that can actually make a big difference. Try to implement them at this point because you know what's going wrong after your initial assessment. Decide what the etiology is, but initially, what are the likely treatments required and expected clinical course. At this point, also, you would know if you had given fluids and if you had given oxygen, you would know if the patient is expected to improve, or if he's still not going to cooperate, or if he's not going to compensate. Is that right? Yeah, compensate after all of your treatment measures. What would you do then? Which teams would you involve at this point? So that is something also that you will have to think of, and you will start informing the teams. Do not underplay the patient. I know it might seem really nice to say, oh, you know, I've handled all of this, now I've got it under control. It's okay to cry for help at this point, even if you think you might not need it. They will assist the patient and they will let you know, at least they will be aware of the patient in case something goes wrong in the future. So it's always better to involve other teams. So criteria to inform the ITU team or the CCOT team. I couldn't find any particular nice guidelines as such for ITU admissions, but I did get this from a BMJ journal that was established in 1998. And they said that CCOT team or an ITU team should be informed if you think that the patient has threatened airway, inform anesthetist. I don't even call it CCOT, inform anesthetist. All respiratory arrest, respiratory rate of more than 40 or less than 8. Oxygen saturation of less than 90, even after giving 50% of oxygen. All cardiac arrest patients, pulse rate of less than 40 and more than 140, systolic blood pressure of less than 90, sudden fall in the level of consciousness or a fall in GCS of more than 2, repeated and prolonged seizures, and a rise in arterial partial pressure of carbon dioxide. Please involve CCOT team at this point. And when you consider ICU admission, if the patient has 2 organ failures at the same time, or if they have 1 complete organ failure with an impending organ failure, which is about to happen, like most of the cases, it's your kidney and your respiration because they go hand in hand. If one goes, the other one goes. So if there is 1 complete organ failure and an impending second organ failure, the requirement of inotropic support, even after you've given fluids, the patient is NORAD or dopamine, definitely transfer. The requirement of 1:1 nursing care and the need for keeping the patient intubated. They have really poor respiratory efforts. They cannot maintain their saturation or their oxygen levels at this point. So the patient needs to be intubated. Yes, shift the patient to ITU. And an unstable patient, you do some things, the patient gets better. Half an hour later, the patient's still deteriorating. Yeah, so unstable patient. All these patients, you should speak to the ITU consultant and try to get them inside ITU before something worse happens. There's something for HDU as well, which I think is mostly related to CPAP, BiPAP, and when you know the patient is not in this criteria, but still needs observation or constant monitoring, then you would speak to your HDU team and then try to show. But like I said, if you got one of these things happening, or if you've been called to assess a patient and you see that the previous one, you've seen any of this happen, then always talk to the ITU team or the CCOT team and keep them aware of the patient, so that in case something goes wrong, they know the patient already. Now coming to drugs. I've got several drugs listed up, but I'm not going to explain all of the drugs in detail. It is quite vast, and obviously it's not possible to cover all of it in one session, nor will you actually remember any of the drugs or the doses that I tell you right now, because even I hardly remember them. It's quite hard unless you actually implement them in your day-to-day life. So life-saving drugs that you see are adrenaline, atropine, and amiodarone, which are more related to your cardiac causes. Calcium gluconate for your hyperkalemia, and sodium bicarb when you mainly come across acidosis. Analgesia-wise, you've got morphine, fentanyl, and naloxone to treat any overdose. You've got drugs for sedation, such as midazolam, diazepam, and propofol, and local anesthetic ones such as lidocaines. So going into a bit of details, regarding them, adrenaline is naturally produced by adrenal glands. Most of it is now synthetically produced as well, so that they can administer for you during your anaphylaxis or your cardiac arrest. Mechanism of action, to make it short, you know that it acts on two receptors, your alpha receptor and your beta receptor. But adrenaline is more concentrated on your alpha receptor. It acts by reducing vasodilation and vascular permeability, and this is what causes the whole edema and fluid collection in your body when you have an anaphylaxis, or like how the face whole thing swells up. So it goes and acts on your alpha receptors and reduces your vasodilation and vascular permeability, so that all the fluids stay within the vessel and don't go extravascular. Antihistamine and acts on beta receptors as well. That's how it helps with your asthma. It causes bronchial smooth muscle relaxation, also relieves any bronchospasm. That is one of the reasons why it's also used in acute asthma situations. Uses, like I said, asthma, severe allergic reactions to insects, foods and drugs, allergic reaction to foods and drugs, shock. Like I said, reduces vasodilation, so helps in shock, and obviously in cardiac arrest. So you give it every 5 minutes. So the doses, I don't want you to go into the details of it, but the main thing that you have to remember is that when it's IV, it's 1:10,000 dilution, and when it's IM, it's 1:1,000 dilution. And IV, you can start with 0.5 to 1 milligram every 5 minutes is what I think is followed in the UK. Back where I came from, we used to give it every 2 to 3 minutes. We used to just give it and see how the patient is reacting. Because, yeah, so you give it at 0.5 to 1 milligram. Intracardiac, I've never seen anyone administer it as well, but the dosage is slightly lesser because you're giving it directly into the left ventricular chamber of your heart. You have to be trained and experienced in doing this, obviously. 0.3 to 0.5 milligram. I've never seen it being done, so I can't really talk much about it. And anaphylaxis, again, is intramuscular. You never give IV for it. Adult one is 500 micrograms every 5 to 10 minutes in the anterior aspect of your thigh. I think a lot of people just carry it as EpiPen these days. And children more than 12 is same as adults. Children 6 to 12 is 300 micrograms. Children less than 6 years is 150 micrograms, and children less than 6 months is 100 to 150 micrograms. I'm not sure if this is followed in the UK, but there are also times when we've given adrenaline as nebulization because we couldn't, like, the IM wasn't working. And I've seen that the nebulization actually works really well, but I don't think it's been licensed in the UK to actually use it, but it's quite effective as well. Class 3 antiarrhythmic drugs is amiodarone. Going to the mechanism of action, you've got your cardiac cell membrane, and it mainly blocks the potassium channels. So you know how your Sodium is on the outside, your potassium is on the inside, and your action potential takes place when the sodium comes in and the potassium goes out. When the sodium comes in, it is depolarization, and when the potassium goes out, it's repolarization. So basically what amiodarone does is goes and blocks the potassium channels so that potassium doesn't go out, and thereby repolarization doesn't happen. The whole repolarization gets prolonged. The period that under which repolarization happens gets prolonged, and that is when your actual QRS and your QT interval in your ECG also comes through, and that's where you develop a QRS and QT interval in amiodarone. So try to remember it that way. Amiodarone blocks potassium channels, thereby blocks repolarization, thereby causes QRS and QT intervals. It reduces the automaticity of SA node. This is basically because when there is repolarization being prolonged, there already a new action potential cannot take place, and thereby your conduction velocity goes down, thereby the automaticity of your SA node goes down. It's more of a retrograde thing. So yeah, eventually it goes down, and thereby it reduces the heart rate. Also binds to thyroid receptors. This is because amiodarone in structure is very much similar to thyroxine, and it goes and binds to the thyroid receptors, and thereby can cause hypothyroidism or thyrotoxicosis. Like I said, it reduces the heart rate. So the uses of it mainly are ventricular tachycardia and ventricular fibrillation. And doses. Amiodarone is a difficult one to remember, or maybe it might be the easiest one because it's like a fixed dose. Basically, it needs to reach a particular concentration in blood for it to act. So initially you give a higher dose, and then you eventually taper it down once that concentration has been achieved. So initial dose is 800 to 1600 milligram per day for 3 weeks. And after 3 weeks, bring it down to 600 to 800 milligrams for 1 month. And once you know that the concentration has been reached, you bring it down to 400 milligram per day. And this is all oral. If you're giving it IV, then you'd have to give it as 150 milligram in the first 10 minutes, see how the heart rate is. And then once you know that it's achieved, if it's not achieved, you have to think about the drug. If it's been achieved, come back to maintenance dose of 360 milligram infused over 6 hours, and then 540 milligram infused over 18 hours. Then fentanyl. It's very commonly used. You would have seen a lot of patients wearing fentanyl patches. It is quite effective, and it's much more potent than morphine. So even a smaller dose of fentanyl is like really, really effective, and it's also very long lasting. Mainly acts on the opioid receptors. So if I have to go into the details of it, it is pretty boring. Basically, it acts on the opioid receptors, causes the conversion of GTP to GDP, thereby causes an extra CAMP, and CAMP comes and stops the influx of calcium at the neuromuscular junction. Basically, almost like the potassium channel, where it keeps it in a hyperpolarized state, and thereby stops the transmission of signals in that neuromuscular junction, causes an inhibition of nerve activity, like I said. So the dose that it comes to is 2,500 micrograms every 50 ml bottle. You draw up to 50 ml in the syringe, and then you start infusing it at 0.5 ml to 2 ml per hour. If you want to give a bolus, then you can give 1 ml in addition to what you're giving. Yeah, so the concentration in which it comes is either 50 ml bottles or 10 ml. And like I said, if it's 10 ml, you take 5 bottles of it and keep it 50 ml in a syringe and then start the infusion again. I don't believe it requires any dilution at this point because it's usually through a PCA as well. Morphine, it also acts through opioid receptors and is more commonly used in wards. Like I said, it's not as effective as fentanyl, so it goes up on the pain ladder. Morphine is more on the lower aspect. Morphine, you can give a maximum of 30 milligrams every 4 hours. And this is the immediate release one. The sustained release one, I think everyone would already know. You give it at a dose of 10 milligrams or 20 milligrams twice a day. I haven't given 30 milligrams twice a day. I've given to a maximum of 20 milligrams twice a day for the sustained release one. A maximum of 30 milligrams every 4 hours you can give for an immediate release one. IM is 10 milligrams every 4 hours, and IV is 1 milligram per ml. Then, so when you give it as an infusion, it's 50 mils because it's 1 milligram per ml. You take 50 milligrams and 50 ml, and you give the infusion as 1 to 5 milligrams per hour, keeping in mind that you cannot cross 30 milligrams over 4 hours. So boluses can be given in addition to this 1 to 2 milligrams. PCA is something that we give mostly for post-surgical patients, especially in palliative care and all of that. Fentanyl is given at 25 micrograms, morphine at 1 milligram, and oxycodone at 1 milligram as well. And yes, morphine and fentanyl, they do have a high dependency situation. So you might want to cut it off or restrict it at one point when you know that it's going out of hand. But keep an eye out, basically. Midazolam is short-acting hypnotic sedative drug, has a lot of uses: anxiolytic, muscle relaxant, anticonvulsant, sedative, hypnotic, and amnesic properties. Mechanism is binding to GABA receptors, which potentiates the effect of GABA. GABA is basically an inhibitory receptor, inhibitory receptor. So when it binds to GABA, it has all the inhibitory effects and thereby causes sedation and reduces heart rate, reduces respiratory rate, and all of it in a negative aspect. Dose is 152 to 200 micrograms per kg, and 1 milligram per ml is how it usually comes in 1% dilution. So 1% would be 1 milligram per ml, taken as 10 ml infused with 40 ml. So you take 10 ml of that, mix it with 40 ml of sodium chloride, and then you infuse 5 milligram every hour. Like I said, it's a lot to take. So if you have something to write down, feel free to write it down. If not, I think you will probably get used to it as you keep practicing or when you start using it. This is also at a maximum dose of 30 milligrams over 24 hours. Morphine is 30 milligrams over 4 hours. Midazolam is 30 milligrams over 24 hours. Propofol, very commonly used, especially in EDs. And even in theaters, it's mainly used for induction of the anesthesia. So you give it in the first go, and then you can switch to other drugs to maintain the anesthesia. Rapid onset, that's where you give it for the induction. Less than 30 seconds, the patient is like flat. Last only 5 to 10 minutes, and that's where you add the other drugs to maintain the anesthesia. It's also a CNS depression, and it acts by acting on GABA receptors. Prior to anesthesia and procedures, used in refractory status epilepticus, many other drugs like phenytoin, midazolam, all of them haven't worked. Generalized anesthetic, induction and maintenance, sedation, and migraines as well. Usually comes in 2% solution, 1% solution as well. Comes as 20 milligram per ml or 10 milligram per ml. Initiation is 2 to 2.5 milligrams per kg until induction onset. So this is when you, it's for anesthesia. So you give it at 2 to 2.5 milligrams per kg. So if it's a 70 kg patient, you give about 140 milligrams, which if it's 140 milligrams, you give it at 7 ml for this patient. So 7 ml should have 140 milligrams. So you give that much for the initial induction. And then at a maintenance, you give it at 100 to 200 micrograms per kg per minute. Sedation, again, is very similar. It's difficult to calculate in micrograms. I'm just going to go with 4 milligrams per kg per hour. And you can give it to a maximum of 400 milligrams per hour until you reached your desired amount of sedation. So you give your initial dose, you wait for 5 minutes, see if the patient is slowly dosing off before you give the next, again, similar dose. Lidocaine, commonly used again. You give it for local anesthesia, and it is also got antiarrhythmic properties because it blocks the sodium channels up in the heart and thereby stops impulse generation. It also decreases the contractility and excitability of the heart and thereby stops the signal from going through the Purkinje fibers and thereby stops the arrhythmia. IV, when you give it, is mainly for when it's used as an antiarrhythmia drug. So it's 25 to 50 milligrams per minute. Again, when you give it, you wait for 30 minutes, see how the patient's heart rate is coming down, and then give the next dose. You can only give a maximum of 300 milligrams. So keep an eye out and make sure you time the doses properly, that you don't give it too early or give it too late, then proper concentration might not actually be achieved in the blood. When you give it local, it's usually as 1%, and if it's a 1% solution, each ml contains 10 milligrams, and what you can give for a patient is a maximum of 3 milligrams per kg. So if the patient is again 70 kgs, you give it 210 milligrams, which is 21 ml max. So for a 70 kg patient, you can only give 21 ml max, even if you're giving subcutaneous and you're giving it locally. Not exceed. If anyone has any questions, please feel free to ask. If not, and if you want to think about the questions, feel free to think about the questions as well and drop in an email or drop in a text, and we'll be happy to reply to all of that. All right. I know it was pretty vast. I know that was a lot taken in a very short period. So I'm sure you have questions. If you have questions, please do let us know. And I'm happy to. I'm just going to wait for about 2 minutes to see if anyone's doing anything. So if anyone's, I guess no one's got any questions, I'm happy with that. Cool, and thank you so much. I'll see you in my next session. Bye.